definition and a core pathophysiology of meningitis. So basically, meningitis involves the inflammation of the leptomeninges and the cerebrospinal fluid adjacent to it. The leptomeninges consist of the pia and the arachnoid mater of the brain, which basically comprises of one of the outer parts of the brain, as shown over here. You can see the cerebral cortex just sandwiched underneath it, and you have your dura mater, the arachnoid mater, and then your pia mater. And because this is the arachnoid mater, the subarachnoid space should be located over here. So remember, this is a dura mater. This is the arachnoid mater. Right over here is the pia mater. And then just this space over here is your subarachnoid space. And a meninges or meningitis involves the inflammation of, I would say, about here, this part of the outer layer of your brain. So it is usually due to the infection, but it can be inflammatory, malignant, or drug-induced as well. So the way this works is that the pathogen will first enter the bloodstream. If it's due to some infection, then it's going to cross the blood-brain barrier, and this is then going to trigger some inflammatory cascade involving increased in cytokine, and then this is going to lead to more inflammatory destruction of the blood-brain barrier, thus increasing its permeability, and that is then going to contribute to cerebral edema, along with increased intracranial pressure and decreased cerebral perfusion. Because remember that the intracranial pressure and the cerebral perfusion are usually inversely related. But in any event, just remember that there's going to be some cerebral edema, and this is going to be noted on CT or MRI findings when doing imaging. But clinically speaking, the classic symptoms you'll see include headache, vomiting, altered mental status, and herniation risk. So, classification is very important for understanding the etiology of the meningitis. You can have bacterial meningitis, where this can present with medical emergency, along with associated symptoms of sepsis, and altered mental status, and respiratory compromise, or I should say confusion and respiratory compromise. You can also have viral etiology, which tends to be the most common cause of the meningitis. You can also have tuberculosis, fungal and parasitic causes. And once again, remember that there are some non-infectious causes out there of meningitis. They include autoimmune diseases. They also include malignancy or cancer, and then some drugs. You can also classify the meningitis based on their time course. So, for acute meningitis, which means it can last from hours to days, this is typically caused by some bacteria or virus. For subacute or chronic meningitis, which occurs from weeks to months, this is typically due to tuberculosis, fungal, or malignancy etiology. So now that we identified the possible etiologies, it's time to break down the causative organisms if the meningitis has some infectious etiology. We can break this down by age and risk factor classifications. So, and it's important to know these very well. So for neonates or individuals who have just been born, the common culprits for the meningitis This is important for adults greater than 50 years old or for anyone who is immunocompromised. So if they have a CD4 plus count less than a certain value that is needed for them to be immunocompetent, the common culprits of the meningitis include the Streptococcus pneumoniae, the Listeria monocytogenes, or some gram-negative bacilli. And that is why the CDC recommends that anyone who is, I think, age 50 or older, that they get the pneumococcus vaccine, and that is to protect against the Streptococcus pneumoniae. And then there are some special situations where meningitis can occur, or that can enhance susceptibility to infections. So, if someone has some basilar skull fracture, this can increase susceptibility to Streptococcus pneumoniae infection and thus meningitis. Also, if there's some neurosurgical operation going on, or if there's some shunts created, this can lead to infection by Staphylococcus aureus and coagulase negative Staphylococcus that can also lead to meningitis. That is why in surgeries in general, prophylactic antibiotics are important. And then you also have human immunodeficiency virus, or HIV, that decreases a CD4 plus T cell count, or the helper T cell count. And what's going to happen is that this is going to enable infectious etiologies like the tuberculosis bacteria, or the tuberculosis mycobacteria, or the cryptococcus fungus, to take the opportunity to infect patients who are already immunocompromised. And that's why these are opportunistic infections. And they can lead to meningitis as well. So for clinical features, we have the classic triad. The triad of symptoms consists of fever, neck stiffness, and altered mental status. However, only about 40 to 50% of the patient population who are diagnosed with meningitis happen to have all three of these symptoms. And then some other key symptoms and features to watch out for include severe headaches, photophobia, nausea and vomiting, seizures, petechial rash, and any signs of increased intracranial pressure. Basically, if a patient presents with some petechial rash along with actually, I got that confused. No, never mind. The one I was talking about is simply used to test for coordination. The Kernick sign is actually where you raise the leg of the patient, you raise it upward, and if the patient complains of pain, then that could be a sign of meningitis. And this is when the patient is in a supine position, or in other words, lying down. And you have to raise the leg to 90 degrees, perpendicular to the patient's body. Alright, so for diagnostic approaches, always consider the initial priorities with stabilizing the patient. So remember your airways, breathing, and circulation. Make sure they're intact. Always obtain blood cultures to see if there is infection going on. And then, whenever you suspect meningitis, be sure to start empiric antibiotics as soon as possible. This is important for controlling the infection, and it's especially important if lumbar puncture is delayed. Oh yeah, one more thing I forgot to mention is that these physical exam signs, like the nuchal rigidity, Kernick sign, and Brzezinski sign, they can be useful, but they have low sensitivity, which means that if the patient doesn't have any of these signs, that does not necessarily mean they don't have meningitis. So keep that in mind. And then, before lumbar puncture is done, make sure to have a computer or CT scan of the brain. And this is especially if the patient presents with focal neurological deficits, new-onset seizures, papilloedema, altered mental status, or immunocompromised state. And then, once we get the lumbar puncture done and we have the cerebrospinal fluid sample, now we can analyze the components in the CSF fluid. So the first thing to look for is the opening pressure. If the opening pressure is significantly elevated, then the etiology of the meningitis is most likely bacterial. If the opening pressure is normal or slightly elevated, then it's probably due to a viral infection. And if the opening pressure is elevated, but not to a significant degree, then the etiology is probably tuberculosis or fungal. And you can always think about this in a clinical context. The patient had subacute signs or chronic signs, meningitis, you can think of tuberculosis and fungal etiologies. For white blood cell presence, if there's increased levels of neutrophils, then the etiology is most likely bacterial. If there is increased lymphocytes, then the etiology is probably either viral or tuberculosis/fungal. For the presence of proteins confuse this with indicating it's gram-negative, because it does not mean that. It's only gram-negative if you have gram-negative bacteria involved. Okay, and then the empiric treatment principles are the following. So you need to start immediately the following medications like ceftriaxone and vancomycin. Remember that ceftriaxone is a third generation cephalosporin. And then ampicillin and then vancomycin is a very powerful antibiotic. And then you can add ampicillin if the patient is over 50 years old, if they're pregnant, or if they're immunocompromised. And the ampicillin is needed for listeria coverage, especially for patients who are immunocompromised. And then for adjunctive therapy, you can utilize dexamethasone. And this will help to reduce the neurologic complications in cases of pneumococcal meningitis. And it's typically given before or with the first antibiotic dose. And realistically, you should not wait for culture results. You need to start whatever broad spectrum antibiotics immediately, like this combination of ceftriaxone and vancomycin. And then once you get the culture results and the susceptibility test results, you can potentially narrow down the antibiotic spectrum in order to reduce the likelihood of inducing bacterial resistance. So yeah, we have these antibiotics and also an adjunctive therapy of dexamethasone. And then there's some complications you need to watch out for. And so these include raised intracranial pressure, seizures, hearing loss, hydrocephalus, septic shock, and disseminated intravascular coagulation. The disseminated intravascular coagulation is common if the etiology is the Neisseria meningitis, hence the term meningococco, and the hearing loss is prevalent among infections involving the Streptococcus pneumoniae. And then for prevention, it requires the use of vaccines. So we have several vaccines out there to reduce the likelihood of meningitis in the future. These include the Haemophilus influenzae type B, or the HIV vaccine. We also have the pneumococcal vaccine. It protects against the Streptococcus pneumoniae. And then we have the meningococcal vaccine with the serotypes A, C, W, Y. Sometimes it can also include the B serotypes or the seroantigen. Sometimes it's not included because the B antigen is, or the B serotype is not really immunogenic. And so these are the options for vaccination. There's also chemoprophylaxis options in cases of close contacts. These can include rifampicin, ciprofloxacin, or ceftriaxone, especially for possibilities of a meningococcal infection, such as being in close quarters with people who may carry this bacteria. And then there's some red flags you should never, ever miss out on. And these include the triad of fever, headache, and altered consciousness. And then rapidly progressive symptoms, any sign of petechial rash, and shock symptoms, or discussed earlier with that table, and also know the age-based organisms and antibiotic choices corresponding to these. So that's a pretty hefty overview of meningitis and its clinical characteristics and pathogenesis. Please comment down below any other clarifications or any other information that needs to be known regarding meningitis. Otherwise, I hope you found this video to be somewhat educational, or at the very least relaxing. I hope to make more videos like this in the future. So in the meantime, please take care, stay well, and stay safe. And most importantly, stay